things that I would be relatively easy testable material for you. So, 43-year-old man presents to the ED with dizziness and a 6-hour history of passing maroon stool. He has been in good health with his only medical problem being depression. He's taking sertraline as his only med. On exam, blood pressure is 100 over 60. Pulse is 100 lying down, and it goes up standing up. Rest of the exam is normal. Lab hemoglobin 10, hematocrit 30, uh, white blood cell count 4.6, platelets 175,000, sodium 142, chloride 100, bicarb 24, potassium 38, BUN 38, creatinine 1.1. What is the most likely source of bleeding? Is it a gastric ulcer, a Meckel's diverticulum, an AVM, diverticulosis, or hemorrhoids? Okay, so it looks like 44% of you, let's see this and share this. 44% of you like gastric ulcer, which is correct. And then it looks like AVM was popular as well. So the key thing in this case is some of the clues we see with the lab. So BUN is very high, and the BUN to creatinine ratio is extremely high. It's greater than 30 to 1. And when people have an upper GI bleed, they frequently will get a remarkable BUN to creatinine ratio. You can see 30, 40, 50 to 1. So when you're looking at a GI bleed and it's person passing maroon stool or something where you can't be sure if it's lower or upper, looking at the BUN to creatinine ratio can be extremely helpful. When we look at some of the factors predictive of it being an upper GI source, the person telling you melena is helpful. Actually, seeing melena is better with a likelihood ratio of 25. Blood or coffee grounds in the NG is very good with likelihood ratio of 9.6, but close to that is a BUN to creatinine ratio over 30 with a likelihood ratio of 7.5. So we do use this clinically. Now, this patient was on sertraline, and sertraline increases the risk of GI bleeding in everybody on it. It's not a huge relative risk, but it can be a risk factor. And in studies, you can see odds ratio 1.41, 1.66. But if a person takes an SSRI and they add an NSAID to it, it bumps this odds ratio up to 4.25. So we know NSAIDs are a problem as far as GI bleeding. SSRIs, a little bit of a problem, but when you add them together, you get a bigger problem. A 60-year-old woman presents her evaluation of hematemesis. She woke up this morning and felt nausea, then vomited bright red blood. She has a history of GERD for the last 2 years that has not been well controlled with 20 milligrams of omeprazole. She undergoes endoscopy. So we have a 60-year-old vomiting blood, nausea, then vomited bright red blood, history of GERD for 2 years, not well controlled with omeprazole. She undergoes endoscopy. And here's what you see. What is the most likely underlying disease? Hereditary hemorrhagic telangiectasia, hepatocellular carcinoma, scleroderma, primary sclerosing cholangitis, or Helicobacter pylori. So the right answer here is the one that was the most popular answer, which is scleroderma in this person with watermelon stomach. We look at the pic, we look at this, and it looks like a watermelon. It's a great description of what this looks like. And watermelon stomach is not only seen with scleroderma, but in the setting of an individual with refractory reflux disease, it isn't responding to a PPI. and they continue to bleed, that strongly suggests scleroderma. I think that if I didn't give you other clues, other things are in play. So this is a cause for chronic blood loss, upper GI bleeding. The one that I think is most testable is its association with scleroderma. And if they ask for what lab test would you order, you'd want an anti-RNA polymerase 3 antibody. So if they could switch this and show you the picture and say, what test do you want, as opposed to just asking for the diagnosis. It can be seen in patients with cirrhosis, although they usually don't have the dramatic watermelon stomach. You can see this with bone marrow transplant. And then the older the patient, sometimes we never find out the answer. So I just wanted to take a second to kind of go through some of the gastrointestinal manifestations of scleroderma. These patients can have severe refractory GERD even when they're put on appropriate therapy, put on twice daily dosing of high doses of proton pump inhibitors. They still can bleed through that. We showed you a picture of GAVE. Patients with scleroderma frequently get severe gastroparesis, and because of that, they get SIBO, that their small bowel, just things don't move, and they can get bacterial overgrowth. They can get life-threatening intestinal pseudo-obstruction, and if you get an upper GI with small bowel follow-through picture and they show you multiple small bowel diverticula, I would pick scleroderma as a cause for that. Usually we don't get a lot of diverticula in the small bowel, but patients with scleroderma do. A 44-year-old woman presents with abdominal discomfort. She's had pain in the right upper quadrant for a few weeks. Her pain improves after she eats. She's also noticed black tarry stools over the past week. She's had noticed more bloating recently, blood pressure 96/60, pulse of 90, abdomen soft with mid-epigastric and right upper quadrant tenderness. Hemoglobin 10, hematocrit 30, white count 9, transaminases and alk phos are normal. So has an anemia, right upper quadrant tenderness. What is the most appropriate next step? Abdominal ultrasound, contrast CT, MRCP, upper endoscopy, or a trial of a proton pump inhibitor? So you did well on this one. The point of this question was, what are what are the clinical indications of upper endoscopy? And she meets clinical indications for going to an upper endoscopy. Frequently, when people have upper GI symptoms, we will give them a trial of a PPI, which is very appropriate with reflux disease and in a few other clinical conditions. But because she has the anemia, and because she gives you a history of melena, this patient should get an upper endoscopy. So these are important indications, and knowing these to help you with answering these questions. So we look for alarm features, and we consider those people over 50, patients who have anemia and upper GI symptoms, melena and rectal bleeding, weight loss with upper GI symptoms, anorexia, early satiety, vomiting, dysphagia, prior gastric surgery, if you find a mass on exam, or a family history of upper GI malignancy in a first degree relative. Those are all clear reasons to do an upper endoscopy. The second indication is if they don't have alarm features, but you have had a very appropriate PPI trial and they continue to have upper abdominal symptoms, then considering an upper endoscopy in those patients. So most common thing we see with this patient likely had a duodenal ulcer, and the majority of duodenal ulcers are H. pylori related disease. But we also sometimes see other H. pylori related disease, malt lymphoma. Those patients, we can cure their malt lymphoma with H. pylori eradication. So with H. pylori treatment, we can actually cure that. Patients who have chronic H. pylori can have chronic gastritis, atrophic gastritis. You can see H. pylori disease in people with chronic iron deficiency anemia because of their inability to absorb it, because they don't make acid and they can't absorb iron. It is associated with ITP, B12 deficiency, as well as a risk factor for gastric cancer. A 76-year-old man, 1 week post PCI with stent placement in the LAD, presents with dizziness and melena. He undergoes an urgent upper endoscopy and is found to have a 4 millimeter gastric ulcer. Meds are aspirin 81, clopidogrel 75, rosuvastatin 20, blood pressure 110/70, pulse is 100, hemoglobin 11, crit 33, white count 7,000, B130, creatinine 0.9. What do we recommend? Begin pantoprazole, stop aspirin for a week, begin pantoprazole, stop aspirin and clopidogrel for a week, or begin famotidine and stop aspirin for a week. Which of these do we recommend? You folks all have a lot of good hospital medicine background. You absolutely nailed this. This person does not need to stop their aspirin or clopidogrel, and they shouldn't because they're a week after stent placement. They're in the highest risk for thrombosis of their stent. So we keep them on aspirin, we keep them on clopidogrel, and we start pantoprazole. And the reason we can do that is he's stable. Okay. The person's blood pressure is okay. Hemoglobin and hematocrit are not down at a critical level. So we can go ahead and just start the PPI. So when we look at patients who have had a recent PCI and they have an upper GI bleed, if it's in the first 3 months post PCI, continue dual antiplatelet therapy unless bleeding is life-threatening. And we didn't have that in this patient. Treat with a PPI. There was some concern a decade ago about PPIs potentially, especially omeprazole, potentially affecting clopidogrel metabolism and making clopidogrel not active and effective. The answer is we can treat them with a PPI. Do not worry about that. These patients should have endoscopy. Usually they should get an endoscopy to see if they need any endoscopic intervention because we are going to keep them on their aspirin and their clopidogrel. An 86-year-old man presents to urgent care for a 6-hour history of bright red bulb per rectum. He was in his usual state of health until last night when he had onset of mild left-sided abdominal pain, most prominent in the left upper quadrant. This morning, he's had 4 episodes of passing bright red bulb per rectum. He has a history of diverticulitis 4 years ago, hypertension, coronary disease with a stent 2 years ago, and a AAA with repair 8 years ago. So he's got a lot of concerns here. He's on valsartan, chlorthalidone, amlodipine, atorvastatin, and aspirin. Blood pressure is 90/60, pulse is 90, temperature is 37, abdomen is non-tender. Hemoglobin is 12, hematocrit is 36, white count is 8,000, platelets 180,000, lipase is 10, AST is 20, ALT is 19, alk phos is 100. So older man, a little bit of left upper quadrant pain. Last night, 4 episodes of bright red bulb per rectum with a complicated history of diverticulitis, coronary disease, and a AAA repair. He's on a bunch of meds you'd expect him to be on, including aspirin. Labs aren't all that exciting. What is the most likely diagnosis? Colon cancer, AVM, enterohemorrhagic E. coli, ischemic colitis, or an aortoenteric fistula? Yeah, ischemic colitis is the right answer here. Um, Nobody chose aortic enteric fistula. I think that's correct not to choose that. He's had a little bit of bleeding without any hemodynamic instability. Didn't really drop his crit all that much. Not something we usually see with aortic enteric fistula is usually a massive bleed. AVMs and colon cancer are on the differential, but they're much less likely than ischemic colitis. This is a gentleman who has atherosclerotic disease as manifested by his AAA and his stent. So we've given you multiple risk factors for atherosclerotic disease. If you look at it, I didn't give you diverticulosis because that would be probably the most common reason. He had a history of diverticulitis. If I gave you that choice, I would have picked diverticulosis. The next most likely thing is ischemic colitis. If you look at malignancies, that's less common. AVM's even less common than that. So in a person with heavy, heavy history of atherosclerotic disease, sort of pretty asymptomatic GI bleeding, except for the fact he's had 4 episodes, I would favor ischemic colitis here. So it's most common in the very elderly, especially those in their 80s and 90s who have multiple cardiovascular risk factors or have known atherosclerotic disease. It has been described in younger patients with hypercoagulable states, and the drug allocetrone, which is a drug used for irritable bowel syndrome, has been description of ischemic colitis occurring with that, especially in women. Symptoms are very minimal other than bright red blood. These patients usually don't have severe pain. They just are more freaked out by the bleeding. Diagnostic testing, contrast CT is reasonable, sigmoidoscopy, colonoscopy, and just really supportive care. We really only consult surgery if they are really unstable, severe signs, but almost all these patients do well with fluids, watching them for a little bit until they stop bleeding. And the majority don't recur. It's really comforting that over 50% of these people, over 50%, don't recur even when they have an episode of ischemic colitis. So, what are some summary things we should know about management of lower GI bleeds? In the unstable patient, CT angiography, if no diagnosis, do an upper endoscopy. We don't want to miss an upper GI bleed, even though we think it's a lower GI bleed, because the upper GI bleed in an unstable patient may need emergent treatment. Unstable patient, CTA shows a source. We're going to do angiography with embolization. Major bleed but stable, you can do a colonoscopy first. Transfusion thresholds are 7. If they have cardiovascular disease, we transfuse at a little higher hemoglobin of 8. Aspirin for primary prophylaxis. If the person has a lower GI bleed, permanently stop that. You know, we aren't all that excited about aspirin for primary prophylaxis these days, and certainly not in somebody who's bleeding. If they have secondary prophylaxis, somebody with cardiovascular disease, we don't routinely stop it after a lower GI bleed. If they're on a DOAC, we usually stop it for a week and then restart it. We will only use the DOAC inhibitor if there's a life-threatening hemorrhage. A 40-year-old woman is evaluated for an 8-hour history of epigastric pain that radiates to the back. She's had nausea and vomiting today. She's recently binged on alcohol, drinking a fifth of gin and 15 beers in the last 24 hours. Labs show a white count of 16,000, a BUN of 30, a creatinine of 1.2, lipase of 800. Ultrasound shows no gallstones. Patient has pain for 48 hours with continued nausea. A CT scan shows non-contrast enhancing areas of the head and body of the pancreas, consistent with necrosis and peripancreatic fluid collection. So, person who's been binging has an incredibly high lipase, high BUN to creatinine ratio, very high white count, consistent with pancreatitis. This patient has a CT which shows necrosis of the body of the pancreas and peripancreatic fluid collections. What is the most appropriate management? Drainage of the fluid collections, enteral feeding by nasojejunal tube, TPN, ERCP, or imipenem. So the right answer here is B. And I wanted to do this question because there was a period of enthusiasm for treating these patients with imipenem, and that period has ended. So if you get a question on the boards, imipenem will not be the right answer in most cases. Certainly not for a patient like this, where it just looks like they got necrotic. We don't really have anything really going in this patient. Certainly if they had positive blood cultures, if the patient was getting sicker and sicker and sicker, maybe, but that standard giving broad spectrum antibiotics when people have necrotic pancreatitis, we aren't doing it anymore. So what really has opened up an era where we really realize what we need to do is get these people well nourished so they can heal. We need to feed them. If a patient isn't vomiting and they can eat orally, you could do that. But these patients that are this sick and vomiting, we're probably going to put a tube in and feed them. And the nasojejunal tube is a good option. If they can't tolerate that, yes, I would go with TPN, but we're going to try the GI tract first. So, bottom line for acute pancreatitis, you're all aware aggressive IV fluid management goes without saying. LR, probably the preferred fluid and really aggressive there. Good pain control, oral or enteral nutrition preferred over TPN, and no prophylactic antibiotics. A 68-year-old woman presents with abdominal pain. She's had a 2-day history of left-sided abdominal pain. She's felt warm but not had any chills. She has not had any dysuria or flank pain, no nausea or vomiting. Appetite is slightly diminished. Temperature is 35.9, blood pressure 130/88, pulse is 90. She has left lower quadrant tenderness on exam without guarding or rebound. Hemoglobin is 12, crit is 37, white count is 11.7. An abdominal CT scan shows inflammation of the sigmoid colon and mesentery. So somebody with left-sided abdominal pain, afebrile, white count 11.7, tenderness on exam, CT shows inflammation of the sigmoid colon and mesentery. Which of the following is the most appropriate management? Admission for IV ampicillin sulbactam, oral amoxicillin clavulinate, oral trimethoprim sulfa, general surgery consult, or liquid diet, reassess the patient in 2 days. So E is the right answer here. This is a person with mild diverticulitis, and we have enough data now to go against the routine administration of antibiotics in everybody with diverticulitis. Certainly, the patients that are sicker, we're going to be admitting them and they're going to get antibiotics. Or in a patient who is marginal, where you're trying to keep them at home, but they have failed conservative therapy, yes, we will start. And amoxicillin clavulinate is a perfectly good and probably preferable antibiotic for diverticulitis, but I wanted to emphasize the shift that has occurred in the last decade of moving away from giving everybody antibiotics for diverticulitis. This is a well-done study published in 2021, a prospective multi-center open-label non-inferiority randomized controlled trial, 480 patients with mild acute diverticulitis. They either got no antibiotics or amoxicillin clavulinate. No difference between hospitalization rate, a little higher in the antibiotic group. Revisits was the same, and pain control was actually better in the group who didn't get antibiotics. A 34-year-old man presents for evaluation of intermittent solid food dysphagia and chest discomfort. He has no significant past medical history. He has tried famotidine without any relief. So this person's having intermittent solid food dysphagia and chest discomfort, tried some famotidine. It hasn't done the trick. Otherwise been healthy. Here is his endoscopy. Picture of his endoscopy with this finding. What is the most appropriate therapy? Sublingual nitroglycerin, sucralfate, fluconazole for 10 days, fluticasone MDI 220 micrograms swallowed twice a day, or azathioprine 100 milligrams a day. Okay, so this is a little harder question. The right answer is D in this patient with eosinophilic esophagitis. And how do I know that? Well, this is a picture you need to know. This is a very classic endoscopy for people with eosinophilic esophagitis. It's sort of a cat's esophagus. I guess cats have all these rings normally, and we usually don't as humans. But individuals with eosinophilic esophagitis will have these multiple rings you can see, and there may be a little bit of a white exudate. Now, I put as a distractor candidal esophagitis with giving fluconazole. The reason we would not pick that would be, first of all, this looks more like an esophagus, somebody with eosinophilic esophagitis. But secondly, he has no reason to have candidal esophagitis. If you get a person with candidal esophagitis, they're going to be somebody with advanced HIV disease. They're going to be somebody who's on lots of immunosuppressive drugs. They're going to have a reason for it. People don't get candidal esophagitis with no good reason. So this has become a more common diagnosis in the last 20 years. It wasn't even discussed back in the 80s, and it's a relatively new diagnosis. Um, think of it in your differential for a young person with dysphagia. They get these multiple rings, often with the whitish exudate. If you biopsy them, you'll see more than 20 eosinophils per high power field. If you can find an allergen that's triggering it, that's the ideal treatment. But inhaled fluticasone swallowed or oral budesonide suspension are the treatments of choice. PPIs long term can help these folks, and dupilumab has been studied for this and might be an option too. But really, on this test, I think they'd have you give them budesonide oral suspension or fluticasone swallowed. A 43-year-old man with HIV disease, most recent CD4 count 75, viral load 1.2 million, presents with dysphagia for 2 weeks. He is finding it very difficult to swallow solids. He has been off his antiretroviral drugs for 2 years. He had stopped them. He didn't like how they felt. And he had read a bunch of stuff on the internet that convinced him that the best thing he could do is stop his antiretroviral drugs. On physical exam, his temperature is 37. His blood pressure is 100 over 60. His pulse is 100. In his mouth, he has white plaques on the buccal mucosa and adherent to his palate. He has significant adenopathy in his neck. What is the next step in management? Upper endoscopy, nystatin switch and swallow 400,000 units 4 times a day, fluconazole 400 milligrams a day, or amphotericin B. So you did well with this. The right answer is treat him with fluconazole. He does not need an upper endoscopy. And there's lots of data from the 1980s, earlier, when we had lots of AIDS cases, and this was a very common presentation of patients in those days. And what was found was that the positive predictive value of oral thrush and esophageal symptoms was very close to 100%. So if a person had thrush on exam and they had dysphagia, they had candidal esophagitis. You didn't need to confirm it with an endoscopy. And these patients do well with fluconazole. Ketoconazole and itraconazole require an acid stomach to be absorbed. And 50 to 60% of patients with AIDS who have advanced HIV disease, who are the patients who are getting this, have achlorhydria, that they lose their ability to make acid. So, You need to give an antibiotic that doesn't require acid to be absorbed. So fluconazole is the best choice. A 47-year-old woman, let's see, I don't think I want it. We did this one yesterday, so we're going to skip this one. A 56-year-old man calls to report an episode of food sticking in his esophagus. He was at a dinner party yesterday and a piece of steak got stuck for about 30 minutes. He reports that this has happened to him twice before in the past few years, but he had forgotten to mention it at his clinic visits. He has a history of GERD, which he takes infrequent PPIs for. He has a 20-pack year smoking history, quitting 5 years ago. He does not drink any alcohol. So 56-year-old, food sticking in his esophagus at a dinner party yesterday. It got stuck for 30 minutes. This really triggered him to come in to see you because he was very panicked and it ruined his night. He said, this has happened twice before, but it got better, so I didn't mention it to you. GERD, takes infrequent PPIs for 20-pack year smoking history, quit 5 years ago, doesn't drink any alcohol. What is his most likely diagnosis? Plummer-Vinson syndrome, esophageal cancer, a Zenker diverticulum, achalasia, or a Schatzki's ring. Okay, so most of you chose Schatzki's rings. Absolutely correct. Totally correct. They're very, very common. They're associated in people with hiatal hernias, people with reflux disease, and they will give this history. He gives a classic history. Piece of meat got stuck. It wasn't moving. Eventually it passed. Sometimes people end up in the ER because the food's stuck there and they have to get it. Need to get something urgently done about it. But the majority of people, it will make their night miserable, but eventually will pass. And they probably auto dilate a little bit during this episode, but then they're going to have it again. So intermittent solid food dysphagia, especially with things like meat or bread, you will see with Schatzki's rings. The best way to really diagnose this is an upper GI. Just go ahead and do a barium swallow, and you can see the Schatzki's ring really, really well. Then these people can get set up for endoscopy with dilation. So almost everybody who has these has a hiatal hernia. It's located at squamo-columnar junction. Classic history is intermittent dysphagia to solid foods, sometimes food impaction and acute dysphagia. Barium swallow, could do an endoscopy, but sometimes it's easier if you see them in clinic, just get a barium swallow the next day. And then in my institution, then I can get them in much quicker for an endoscopy. And then these patients need to get recurrent dilations. The other thing is they probably should be on reflux treatment because reflux makes this worse. A 53-year-old woman presents her evaluation of persistent abdominal pain over the last 6 months. She reports that the pain is a 7 out of 10 located in the right upper quadrant. The pain does not worsen with food, not relieved with bowel movements, no nausea or vomiting. She reports that it is worse when she is sitting or standing, and it is relieved by lying down. She had a history of cholecystectomy in 2016, hypertension and type 2 diabetes. She's on metformin, lisinopril, and empagliflozin. Blood pressure is 130/70, pulse is 80. Abdominal exam, tenderness palpation in the right upper quadrant with no rebound tenderness. Labs are unremarkable. She's got a white count of 5.4, a crit of 44, a sed rate of 13, a CRP of 1, bilirubin of 0.8, alk phos of 100, AST and ALT are normal. So to reiterate, persistent abdominal pain for 6 months, 7 out of 10, right upper quadrant, not worse with food, not better with bowel movements, no nausea or vomiting, worse with lying down, worse when she is sitting or standing, relieved by lying down, history of cholecystectomy, hypertension, type 2 diabetes. What is the most appropriate next step? Right upper quadrant ultrasound, abdominal CT scan, upper endoscopy, or a more detailed physical exam? Okay, you're all good test takers. When you get an outlier like more detailed physical exam, it often is the right answer. And the other answers are what would get done in most places. I can't imagine a world where this person wouldn't be sent for a right upper quadrant ultrasound. There's nothing wrong with that. They might get an abdominal CT scan. There's nothing wrong with that. The problem is you're not going to be able to make the diagnosis with those two tests. But most patients you're going to see who end up with this diagnosis this patient has have had an ultrasound, abdominal CT scan, and an upper endoscopy. And you're seeing them for persistent abdominal pain after the easy workup has been done. So what you need to do is look for a Carnett sign on this patient. A positive Carnett sign is when abdominal pain is increased or remains unchanged with tensing the abdomen or when the examiner palpates the tensed abdomen. So what we're going to have is this patient lie down. We're going to listen. I usually examine with my stethoscope and I'll press with my stethoscope, listen in their abdomen, but I'm pressing to see if they wince or hurt when they're relaxed. Then I will tell them to tense the abdomen. And the easiest way to do this is to have them start to do a sit up. They do about 30 degrees. They got a tensed abdomen there. And then I will go ahead and I'll press the stethoscope hard on their abdomen and see if they wince. Or I will ask them, did it hurt more when I was listening to you and pressing before you started to bend your abdomen or now? And if they say it's much more tender with the tensed abdomen, that is a positive Carnett sign. Carnett sign are associated with chronic abdominal wall pain, okay, and a couple of different diagnoses that can do this. And chronic abdominal wall pain becomes much more common in our patients who have had big workups for chronic abdominal pain. They've had the upper endoscopy, they've had the CT, maybe they had an MRI as well, maybe they've all had abdominal ultrasounds, and all of them have been unrevealing. In a study of almost 2,700, or a little over 2,700 patients with chronic abdominal pain referred to a gastroenterologist, 137 had chronic abdominal wall pain. After 4 years, they still had that diagnosis. 80% were women, and none of these did the referring physician suspect abdominal wall pain. Now, acne is an important cause of this anterior cutaneous nerve entrapment syndrome. So, up to 30% of patients with chronic abdominal pain of unknown origin have this. Estimated incidence is 1 in 2,000, and 88% of these have a positive Carnett sign. And most of these patients have a remarkable response to an anesthetic injection. You find an area that hurts, they have a positive Carnett sign, and then you inject bupivacaine to the area where it hurts into the wall, into the abdominal wall there, and patients will have a resolution of their pain. When you re-examine them, they don't hurt and they'll feel good. Now, about half of these patients have a long-term outcome with that injection. So think about this. Now, what was the risk factor in this patient? It was her prior cholecystectomy. Individuals who have had laparoscopic surgery or open surgeries are at risk for this anterior cutaneous nerve entrapment syndrome. A 56-year-old woman is seen for persistent symptoms of GERD. She first had symptoms 8 years ago. At that time, she had an upper endoscopy that was unremarkable. She was treated with once daily omeprazole, which resolved the symptoms. Over the past 5 years, she's had to increase her dose of omeprazole to twice a day for control of symptoms. If she misses a dose of her PPI, her symptoms return. What would you advise? Upper endoscopy to screen for Barrett's esophagus, ambulatory pH monitoring, esophageal manometry, or check a vitamin B12 level. So we're going to re-go through this complicated history again before we have you vote. A 56-year-old woman is seen for persistent symptoms of GERD. First had symptoms 8 years ago. At that time, she had an upper endoscopy that was unremarkable. She was treated with once daily omeprazole, which things were all good. Over the past 5 years, she's had to increase her dose of omeprazole to twice a day for control of symptoms. If she misses a dose of her PPI, her symptoms returns. What do you advise? Upper endoscopy to screen for Barrett's, ambulatory pH monitoring, esophageal manometry, or check a vitamin B12 level? So this is a little bit of a tricky question. It was a setup. Everybody chose A, but I want to go through guidelines because on this exam, recommendations are going to be based on what are in the AGA guidelines. And, we kind of learn, okay, if people have reflux for a while, they need an upper endoscopy, look for Barrett's. And the real question is, do they? This patient had an upper endoscopy with her reflux 8 years ago, and it was a normal upper endoscopy. So I think probably at this point, I would probably check a B12 level because she's been on BID dosing and proton pump inhibitors, and that's significantly a risk for vitamin B12 malabsorption and deficient B12 levels. So if I'm looking at, there's a couple of things I might consider. One is she's had persistent GERD, and we kind of have this reaction of we should probably scope them, or she's had persistent GERD and she probably should be on B12. I didn't tell you if she is on B12. We didn't tell you about any B12 levels. So, what are the needs for upper endoscopy? New onset of dyspepsia in a patient over 60. She had GERD before and she was worked up for that, had a normal endoscopy. Evidence of GI bleeding, iron deficiency anemia, anorexia, unexplained weight loss, dysphagia, odynophagia, persistent vomiting, or gastrointestinal cancer in a first degree relative. These are our clear indications for upper endoscopy. She didn't really have those. And the key thing is she had a previous endoscopy. If you told me she'd never had an upper endoscopy and she was just treated with a PPI, yes, I would absolutely get an upper endoscopy on her because of the persistence of her symptoms. But with the normal prior upper endoscopy, I wouldn't repeat it. A 51-year-old woman comes to clinic to discuss her GERD. She has been on omeprazole for 6 years, which has been done a great job controlling her symptoms. She has read about some concern about the drug. Let's stop here. I see somebody has a question.
You know that it looks like Andrew, you
Let's
raised your
look at the
hand. I
question
don't.
here. Okay. Don't the guidelines recommend if you're unable to come off a PPI after 8 weeks, they need to reconsider? Well, yes, but I mean that's for a initial EGD. And here's a question because it's been 8 years. So I think those guidelines are for initial. Now, this is a tricky question. I don't think this would be the right question. I don't think this would be a question that you would get. And I don't want to spend too much time on a badly written question because what my point here was to point out that in a patient who's had a endoscopy, 8 years may be a little long, but certainly if a patient's had an endoscopy within the last 5 years and it was a normal endoscopy that did not show Barrett's, that they don't need to keep getting endoscopies to look to see if they transition to getting Barrett's epithelium. There's a little bit more controversy now on how often we should be screening people who actually have abnormalities with Barrett's. So yes, I don't think it's wrong to get an endoscopy in her, and probably not the best question to ask you that. This question's even worse. This question, I really want to just go over this because clinically you have to do this all the time. A 51-year-old woman comes to clinic to discuss her GERD. She's been on omeprazole for 6 years, which has done a great job controlling her symptoms. She has read about some concern with the drug and would like to look at alternative options for her GERD. What do you recommend? Taper off PPI, start an H2 blocker, stop the PPI, start an H2 blocker, stop the PPI, or stop the PPI and recommend refraining from spicy food. So which would you do here? So, yeah, a lot of these choices are correct. And I'm going to go through the guidelines, which don't help us much. So, guidelines would say taper off the PPI is a really, really good idea. Taper off the PPI, start an H2 blocker. But they also say you could abruptly stop the PPI and start an H2 blocker. And I think D, it's interesting because there is limited data on spicy foods triggering GERD. Now, people who have active GERD can hurt a lot more with spicy foods because if they have esophageal erosions, the spicy foods going down, the pH of them might be bothersome for them, but they usually don't create the GERD. But it's interesting to me, the AGA indications for PPIs, we'll go through those, and then we'll go through what they say about taking people off it. Definitive indications for long-term use: Barrett's esophagus, erosive esophagitis, eosinophilic esophagitis, esophageal strictures associated with GERD, Zollinger-Ellison syndrome, and IPF. These are all reasons to keep people on long-term PPIs. Conditionally indicated for long-term use: PPI responsive to GERD with recurrence off the PPI. So when you take them off, it comes back. PPI functional dyspepsia with recurrence off PPI. PPI responsive upper airway laryngeal symptoms with recurrence off PPI. So patients who have asthma where they get better control when they're on a PPI and it gets worse after. Not indicated for long-term use or obvious: non-erosive esophagitis without response to high-dose therapy, functional dyspepsia with no sustained response, so it doesn't work for functional dyspepsia in a patient, don't keep them on it. Steroid therapy in the absence of taking a second drug like aspirin or an NSAID. Now, here is what's frustrating. Here is the AGA. We go turn to them to give us clarification on deprescribing PPIs, and they give us this. Most patients with an indication for chronic PPI use who have taken twice daily dosing should be considered for step down to once daily PPI. 80% of patients on high dose PPI could reduce. Fine, we know that. The insurance companies tell us to do that. Patients who discontinue long-term PPI therapy should be advised that they may develop transient upper GI symptoms due to rebound acid hypersecretion. When deprescribing PPIs, either dose tapering or abrupt discontinuation can be considered. So they say you can do what you want. You can either dose taper or you can abruptly discontinue it. I think using an H2 blocker to help these patients is also a useful thing. So I just wanted to point out there isn't a end all on the taper discussion versus abrupt discontinuation of PPIs. A couple of words on vonoprazan. I don't know if any of you have gotten a chance to use this drug yet. I've been out for a couple of years, so it's possible it could show up on the boards. Generally, any drug that's been out for less than 18 months doesn't show up on the boards. It's a potassium competitive acid blocker that inhibits acid secretion at the hydrogen potassate ATPase proton pump. It's been used for over 10 years internationally, and it's been quite effective. It's certainly a great option if somebody has an allergic reaction to PPIs. This is something different than a PPI and can be used. It's also indicated for patients who have not had response to it. The biggest problem with this drug is getting prior authorization for it. So this was FDA approved in 2023. So now being out for 3 years, it's something that could show up on the boards. If you look at cost of these, the vonoprazan is $700 for 30 days. So if a patient can't get prior authorization, they're not going to be able to afford it. So indications: it's more effective than PPIs for severe esophagitis, non-inferior to PPIs for ordinary GERD symptoms. Adverse effects are infrequent and similar to PPIs. Um, it's FDA approved for only 6 months, and the real limitation is how high the cost is. Okay, well, we'll stop there. I'm happy to handle if you have any questions from any of the talks I've given in the last 6 days. If something hasn't been clear or you have, a concern about one of the answers, I'm happy to handle that now or any other questions you have. Okay. Well, thank you for, I know it's not easy to sit listening to somebody for 6 hours, but you folks have paid attention. You've done remarkably well I think I'm a much harder question writer than most, and you folks have done great with these questions. And a lot of times I try to give you what I think you might be asked, and sometimes I give you questions just to try to bring up a topic that often is complex, and some of those questions are really hard. So you've done great with them.
Well, thank you so much. It is always a delight, and I always learn things from your talks, no matter how many times
Okay, well,
that I get
thanks
to
for
listen.
having me.
All right. So we have one more speaker for diabetes, and I don't see I don't see Dr. Renzel on just yet. And I think her talk we're planning for 3:15. So we'll go ahead and we'll take a break. We will plan to meet back at 3:15 to finish up.